That's obviously not my heartbeat because it would be going a lot faster than that. Good morning. Thank you for the introduction and welcome to the audience here in Stockholm. Welcome to the cage. Welcome to everybody who's watching this around the world. My hashtag or my Twitter handle is @NightShiftMD in case you want to follow me, and I'm really thrilled to be here to give a physician, an MD or health professional cultural perspective on various aspects of disruptive innovation in digital health. What I want to talk about is why we need disruptive innovation in healthcare, why physicians and other healthcare providers need it. I'm going to provide some successes, in particular, the new people in healthcare who are making a difference, either established jobs in healthcare where people are doing things differently, extending their scope of practice, and new people, that's health coaches. And then I'm going to talk about a very exciting development, patient and family-centered care. And then finally, we'll get to digital health and why I think digital health is the catalyst for disruptive innovation in healthcare and a way to bring doctor and patient, healthcare provider and patient and family together. I think we all know the definition of disruptive innovation, but it never hurts to make sure that everybody's up to speed. Disruptive innovation means transforming an existing market or sector by introducing simplicity, convenience, accessibility, affordability, where complication and high cost are the status quo. And this is one of the classic examples. Before Big Blue, before the IBM PC, we had those huge mainframe computers, and that's what people thought of as computers. Nobody dreamt that there would be a computer on your desk, and now, of course, we're walking around with extremely powerful computers. Probably the next generation of computers will be inside our noggins. Now, what is medicine's reaction to disruptive innovation? Anything from denial to boredom to outright rage to confusion to anxiety, and you need to understand that if you're going to succeed with digital health innovations in this world. And I'm going to be talking a lot about that in the first little bit. In fact, I wrote a book about it. The book is called The Secret Language of Doctors. I didn't think it was a book about disruptive innovation, but as time wore on, it became obvious that that's what it was about. The Secret Language of Doctors began as a look at jargon that's used by physicians, and very quickly it mutated into a book about slang. The official name or the formal name for slang is argot. And argot is defined as a secret language used by various groups, including but not limited to thieves and other criminals, to prevent outsiders from understanding their conversations. Police officers have their slang. People who work as air traffic controllers have their slang. Emergency response providers have their slang. And not surprisingly, physicians do as well, working in a highly charged environment. Contemporary slang exists to provide a vehicle for which physicians and other healthcare providers can talk about patients they find frustrating, situations they find frustrating, and colleagues, fellow professionals that they find frustrating. And you know, the trivial part of the book is the slang. The deeper meaning of the book is the premise of the book, that the slang or the argot symbolizes beliefs or attitudes within the culture of modern medicine. And if you want to succeed with innovation, you have to understand the culture of medicine. And one way to understand that is by understanding the language that we use. I would also suggest to you that slang comes from an unspoken desire to resist disruptive innovation. Of course it is. It's coded language that only doctors understand, so they can talk among themselves without you understanding. And they can disrespect what you're trying to bring to the table without you even knowing it right in front of you. So I'm going to choose a couple of fairly polite examples of slang, and then we'll get on to the rest of the presentation. Here's a bit of slang that's often used across many domains in healthcare, and the slang is frequent flyers. Frequent flyers, in the definition is a patient who visits the hospital frequently. And there are, in my book, I have some extreme examples of patients who visit the hospital 500 times over a 2 or 3 year period. It's an extraordinary number of visits. Obviously, they're not paying for it each time. Perhaps it happens more often in a publicly funded healthcare system. It's slang, it's polite, it can be used. In fact, some patients, I've spoken to mothers of kids who are fragile, who have complex needs, and they're almost proud of calling themselves frequent flyers. But within the culture of medicine, frequent flyer is an ironic term. You know, when it comes to airlines, a frequent flyer is a beloved customer. In healthcare, a frequent flyer is not a beloved customer. And there's a whole bunch of reasons why. Now, frequent flyer is a way of disrespecting the patient by focusing on the fact that they're coming often to the hospital or to the emergency department, but not trying to unpack why they're coming so frequently to the emergency department. And this guy, Jeff Brenner, who I'll introduce you to in just a moment, is a disruptive innovator who took the behavior and gave it a neutral term. He calls these patients super utilizers. That just focuses on what they do. It doesn't have the ironic meaning of frequent flyer. Now, who are the people, the super utilizers who come back to the hospital again and again? Well, they're patients with lots of comorbidities who are in genuine need of care, but not acute emergency care. They don't have a cut that needs to be sewn up, a broken bone that needs to be fixed. But as you'll see in a moment, they do need health care. What does the term frequent flyers say about medical culture? It's my job to make you aware of our insecurities. It makes healthcare professionals feel as if they have failed. Because if somebody's coming back again and again, then what more can I offer you? Why are you back? It also speaks to a concept that's very important in healthcare. It's called medical futility. The notion that a lot of the things that we do in healthcare are not effective for many of the patients that we see. Many of the acute care treatments that we provide are not effective for people who have chronic illnesses, and most of the superutilizers have chronic illnesses. Some in healthcare see superutilizers as looking for free meals and free transportation and other perks that they sometimes get when they come to the hospital. I would submit to you that we would rather invent slang and complain about people who come back again and again than do something to address the root causes. That's most of us, with some exceptions. As I said, most of the people who are superutilizers come back again and again. They are the people who have chronic illnesses. And I'm the first person that's going to talk about this, but I'm not the only one. You're going to hear a lot about this in the next 2 days. These people have high blood pressure, diabetes, lung disease, cancer. Cancer is increasingly a chronic disease that people live with for many years. Kidney disease, heart failure, mental health issues, substance abuse. The cost of managing all of these chronic illnesses is 75% of all health care expenditures, which is an astonishing percentage, and if anything, it's going up. Here's the thing. In medicine, we are trained, we are acculturated to want to treat, to be attracted to people who have acute problems and not the chronic problems like these, which is why we often greet people who have these chronic comorbidities with disdain. The other reason why is that if you look at all of those preventable diseases, they have 3 things in common: cigarettes, bad food, being overweight, and being a couch potato. And they're all preventable causes, and that's code for you can blame the patient for having the behavior. And we're beginning to see a revolution in changing that, but it's taking its time. Now, back to the disruptive innovator. That's Jeffrey Brenner. Jeffrey Brenner is a physician who works in Camden, New Jersey, which is one of America's poorest and most dangerous cities. He was interested in why there were pockets of the city that had high crime rates, and he asked for the data, and he received it. And Sweden, of course, is famous for providing good data, and that's a very important thing to be able to answer the questions that we want to answer. Now, Brenner was looking for crime hotspots, places where there was lots of crime, but he discovered something else which was far more interesting to Brenner as a physician. These were medical hotspots. In other words, these were places where there were high concentrations of patients with those chronic comorbidities. And so they might be representing 1% of the total population, but they would be using 30% of the local hospital and emergency department facilities. He could trace it down to individual city blocks and even single apartment buildings where they were high consumers of health care. And he found these spots. They're medical hotspots. And they were filled with patients who showed up again and again to the emergency department. So what did Brenner do? Did he complain about it? No. Did he invent slang? No. He addressed the problem. He got some seed money, and he set up a program to capture superutilizers, the data about superutilizers in the emergency department, and when they were admitted to hospital. He visited them. He had a team that visited them before they were discharged. They accompanied the patients home. They made sure that they got their prescriptions and that they took them properly and that they had follow-up care and that they went to their follow-up visits. You remember I said that that Brenner found that there were apartment buildings that had high concentrations of superutilizers? What did he do? He built a clinic on the main floor of these apartment buildings. And with all of these interventions, he was able to bend the cost curve. He was able to have a population that was better treated and visited the emergency department far less, was admitted to hospital far less, and saved the system money. So that's what happens when you ditch the slang and look at the problem. Now, the slang is helpful if it points you in the direction of issues that need to be fixed, but you've got to be looking for it, and you've got to pick up on the slang. Here's another bit of slang. Of course, we have a silver tsunami, and that's a big picture of the tsunami right now. Seniors are the fastest growing segment around the world. And not surprisingly, the healthcare system has invented slang terms to describe seniors. GOMER, which is an acronym for Get Out of My Emergency Room, that's an old term. Social admission, that's somebody, again, who has to be admitted to hospital not to save their life, but because they can't go home. And often it's said with a sigh and frustration. They're called social admission. Dyscopia. Dys is the prefix for difficulty coping, dyscopia. We're very witty with our language. The worst I heard was a slang term, FTD, which stands for failure to die, as if to say that patient didn't get the memo that their time was up. And so that's a sad bit of slang as well. So what does that represent? Well, that symbolizes our frustration, the frustration of my colleagues, for a number of reasons. One of them is futility, and I think we're all having an honest discussion these days about the futility of our acute medical treatments in the very old, people with dementia, people who don't have a good quality of life, and yet we feel as if that's all we have to offer, and we get frustrated when it doesn't work. The other frustration, though, is this: time. It takes a lot of extra time to sort out the problems of frail seniors and to unpack their problems and to put into place solutions. And that's a problem because across most healthcare systems, we're trying to see patients, people like me, in 5-minute appointments. And when you have and there's a whole bunch of reasons, but it seems to be true in capitated systems, in private and public, and that's a huge problem, expecting to sort out these problems. What you end up doing is what you get paid to do and not what's right to do. And so every patient who takes 5 minutes longer, you've got to take that away from somebody else. You're constantly juggling, and the healthcare professional is under a great deal of stress. And one of the ways to close a 5-minute appointment is a test. Booking somebody for an MRI, for a CT scan, or some other test, which wastes money and doesn't provide the answers that we need. What do these slang terms have in common? And there's slang, if you read my book, there's slang terms for frequent flyers, for seniors, people with mental health patients, the frustratingly untreatable, and the futile. Well, what they have in common is that the slang term is all about us and not about the patient. and that's a problem. So when you do that, you're showing empathy for yourself, but not empathy for the patient. And that is the biggest problem I would suggest to you in healthcare. There's many reasons why healthcare professionals aren't the most empathetic. I think medical culture devalues empathy, sees it as a soft skill that you offer when your clinical acumen isn't as good as it could be. There's lack of training on the empathic response in healthcare. There's a belief that it's a personality trait. You either have it or you don't. Time pressure. It's hard to be empathetic in 5 minutes. It really isn't if you know how to do it, but it just means putting yourself in the place of the patient. Technology is interesting. I think technology can enhance empathy, but at the same time, if you're spending your time looking at the computer screen and not at the patient, you're going to have trouble empathizing with the patient. I think another reason is specialization. Specialization itself is not the problem, but it leads to fragmented care. It leads to people in their different specialties doing their job properly, but nobody's taking care of the patient. And nobody's taking care when the patient is falling between the cracks, which happens very often in a fragmented system. It happens certainly in my own country, Canada. I've spoken to physicians here who say it happens here in Sweden, and I'm sure it happens everywhere else. Okay. What do you do when opportunity knocks? Well, there are things that can be offered that can give physicians more time and more opportunity to empathize with patients. The first is a radical shift, and this is probably one of the most important disruptive innovations in healthcare. Transferring skills from highly trained but expensive personnel, that's us, to more affordable providers, often using technology, shifting care from hospitals and clinics to offices and patients' homes. Those are the two big disruptive innovations. Let's take them one at a time. Let's talk about other people doing the jobs that in some countries physicians do. Well, right here in Sweden, midwives have been doing this for centuries. You know, in Sweden, midwives attend, 80% of all births, because the majority of them are low risk, low complications, and obstetricians are only brought in when their skill is needed to deal with complicated deliveries and postpartum complications. In my province, Ontario, Canada, midwives attend just 6% of births, and obstetricians attend more than 80%. That's expensive. They all deliver good care. But obstetricians, the studies show, use more interventions, and they cost more, and they don't necessarily have better outcomes than midwives have. They certainly have a higher cesarean section rate, that's for certain, because in most developed countries, midwives don't do cesarean sections. Let me give you 3 examples of this very kind of disruptive innovation that's taking place. 3 problems, 3 solutions. In Ontario, 800,000 Ontario residents can't find a GP, a family physician. So these 2 women, Marilyn Butcher and Roberta Heel, set up the first nurse practitioner family practice clinic. It was so successful, there are now 25 others, and there'll be even more. So nurse practitioners, intermediate scope of practice between a nurse, a registered nurse, and a family physician. That's solution number 1. Problem number 2, surgeons can't do enough hip and knee replacement operations at a hospital in Winnipeg, Canada. Solution, hire physician assistants. These are people who have surgical skill. They are trained by the surgeons they work with, but they are not surgeons. They're an extra pair of hands for the surgeon. And in that one hospital, Concordia Hospital in Winnipeg, they hired these physician assistants, many of them physicians from other countries, and taught them what they needed to do to open and close the wound. The orthopedic surgeon scrubs in just in time to put in the hip or knee replacement, scrubs out, moves on to the next operation, goes back and forth, and within 1 year, they had doubled the number of hip and knee replacements without having to hire a single orthopedic surgeon. So that's another innovation. Third innovation, third problem, paramedics, by law, would have to take patients from nursing homes to the hospital if they had anything from dehydration to a fever to a cut that needed stitches or a broken bone. Solution, paramedics in Nova Scotia trained to visit the long-term care facility and treat older patients to the best of their ability to avoid a trip to a hospital. And guess what? They were able to prevent 73% of the unnecessary visits, unnecessary transports to the hospital. So you can see how that can work. Here's another innovation that you should be aware of. Health coaches. The problem is that we spend too much money on MRIs and hospital care and don't get very good results. So the solution, and we're starting to see this in some clinics in the United States, is to take money away from acute care, take money out of MRIs and surgeries and hip and knee replacements that aren't necessary, of course. Take that money and put it into primary care. Not more doctors, hiring health coaches. Health coaches are peers. They are people who are fundamentally lay people. They are not professionals. It's an entry-level position. And what a health coach is I would say very close to having that family member who's wise about healthcare, but not a professional, and knows how to ask the right questions, and knows how to kind of break down the things that need to be done into manageable steps. So the physician sees the patient with new onset diabetes, type 2 diabetes and hypertension, and writes a prescription. Here are your pills, 2 kinds of pills, and here are your blood pressure medications. Here's 2 more. And you should lose 15 kilos if you can. We'll see you in 8 weeks. What happens the next day? In most family practice clinics, nothing happens the next day. But with a health coach, if they have a health coach on board, they phone up the patient and say, how are you doing? Or they text them, how are you doing? Not so good. Did you get your pills yet? No. Why not? Well, I was babysitting my granddaughter because my daughter is a single mom and she has to work. And, oh, wait, you couldn't get your pills. I'll get them for you. Have you started exercising? Oh, no, I haven't. Well, you know what? I'll meet you tomorrow at 2 and we'll go for a walk together. And the best way to know how well somebody's handling a fitness routine is to walk with them. And so they walk with them. And in the experiments in which this kind of model is being used, you have healthier patients who spend less time in the hospital and lower the cost. Again, you have fewer frequent flyers, if we're going to call them that. More disruptive innovation. Let's move to disruptive innovation on a hospital-wide scale. All the things that I've talked about have been empathetic to patients. A health coach empathizes with a patient who can't fill a prescription, either because they can't afford it or because they can't manage the transportation to the pharmacy, etc. Now we're going to talk about empathy on a hospital-wide scale. The problem in the culture of medicine is that until very recently, hospitals assumed that patients knew little about healthcare and therefore they didn't have to pay any attention to them. The solution is what hospitals like Kingston General, which is a hospital in Ontario, has done. It assumes that patients know a lot about themselves and are major contributors to how to make the system better. So what Kingston General Hospital did was to invite patients on board, and you're seeing photographs of all of them, and they invited them to tell their stories, and some of them were not nice stories about healthcare, about the healthcare delivered at the hospital, but then they went one step further, and they made these patients an essential part of everything that the hospital does. If the hospital hires a new nurse, they put a patient on the interview committee. Imagine a patient interviewing a nurse, asking them about their empathic skills. If they're going to build a new wing, change the diet in the hospital, order a new MRI, there's always a patient or a family member of a patient on the committee to make sure that the patient's voice is heard. Not for lip service, but to make essential changes. Here are just 3 of the things that have come from patient and family-centered care. Now accepting visitors 24/7. Not too many years ago, visiting hours in hospitals were restricted, and there was no good reason. There was a sense that patients and family members would interact, and it would be disruptive to other patients, and that can happen, but you can make rules about that. And now, many hospitals have moved to unlimited, unrestricted patient care. Patient visiting. Geriatric emergency departments is another one. Here's a third innovation, emergency wait times. Imagine posting online emergency wait times so that it's possible for patients to decide which emergency department they want to go to. Here's another disruptive innovation. Comparison shopping for a car is simple. You just go online and get all the comparators. Comparison shopping for healthcare is almost impossible until very recently. Sweden, through its patient registries, now the United Kingdom, we're beginning to post surgeon and other physician success rates and complication rates online, and so that it's possible for health consumers to make a choice which one do they want. Last few minutes, I want to talk about this. There's no question that digital health, technology, apps are a marriage made in heaven when they're combined with patients who are looking to become equal players on the team. And I'm not talking about Fitbits here. They're wonderful devices, but compared to what we're about to see, they're toys. So the first person I want to introduce you to is Joe Cafazzo, who is the chair or the head of Global eHealth Innovation at Mars, which is a major hub for global eHealth innovation in Toronto. And he has developed an app to self-manage diabetes. Let's have a listen to that.
Right? What if we could create a technology for them that's not this. This is the clunky technology they use now, this meter that just spews out a result and they have to write it down in a little booklet. What if we could create a technology that was on their terms, that had this ability to unlock their ability to care for themselves using perhaps a smartphone? And that's what we did, was we created an app called BANT. Right? And BANT is directed towards them and trying to allow them to care for themselves more effectively. And this is how BANT works. So you take your test strip, you apply it to your glucometer just like you normally would. You take your blood sample, you apply the blood sample. And this glucometer has been modified. We modified it to communicate to the iPhone over Bluetooth. It automatically launches the app, and the blood sugars start transferring automatically. And you know, they're now in context. There's all there. You can look at your breakfast and your lunch readings. You can look at trends, not just a static reading. And there's even a social community so that these kids can connect with other kids with type 1 diabetes. We also introduced a rewards program so that they get experience points for every reading they take. They get a 2x multiplier for taking consecutive readings, and they get bonus points for taking a full 5 readings per day. And they could accumulate these, level up, and then they get iTunes redemption codes to buy music and apps. Oh, hold on. So we tried this at Sick Kids for 3 months, and these kids tested almost 50% more frequently using BANT than in the 3 months previous.
Pretty amazing, huh?
So
let me give you another innovation. Here's an app that helps patients manage their own high blood pressure.
So we take the BlackBerry, and it's communicating with a Bluetooth-enabled blood pressure monitor. So we took 2 groups. We took one group that just had a clunky old blood pressure monitor, and we took another one that was Bluetooth-enabled that communicated with their BlackBerry running our app, that had reminders that would communicate serious blood pressure readings to their family doctor. And we tracked this over a year, and this is what we found. The group that had the clunky old blood pressure monitor, there was no change in their blood pressure over that period of time. Now, the group that had the BlackBerry system, they saw a 20% drop in their risk of heart attack and stroke over that 1-year period. An app that saves lives.
We can go even further. I want you to meet a man named Hugh Campos. Hugh Campos was born with a special heart problem that caused his heart rhythm to develop a rapid, lethal heart rhythm called ventricular fibrillation. It's the #1 cause of sudden death in young people. The cure is an implanted defibrillator which prevents sudden death by administering a shock. Problem is, the shock is not pleasant. And the interesting thing about this device is that it not only delivers the shock, but it senses. It senses the rhythm, and it's recording it constantly. In other words, it's a motherlode of data. And Hugh Campos wanted to know what was causing his episodes of ventricular fibrillation. And so he asked the company for his data. And at first, they refused, and he had to complain, and eventually he had to sue. And he got access. In fact, that's where Dave DeBronkart, ePatient Dave, I know a lot of you are familiar with him, came up with the phrase, "Give me my damn data." Well, what Hugh Campos discovered was that there was a particular type of of alcohol that he would consume that would cause him to go into ventricular fibrillation and cause him to need a shock to save his life. It was not vodka, it was not beer or wine, it was scotch. And he found that by eliminating scotch, he was able to dramatically reduce the episodes of ventricular fibrillation. That is an engaged patient. So the proven benefits of this approach: patients are better informed, they're more motivated, they take their meds better, they do a better job of managing their chronic diseases, which after all we don't want to treat. We have healthier patients, and down the road we have lower downstream costs for hospital care. It's a win-win-win situation. Now, Joe Cafazzo in the first video mentioned how he motivates teenagers. There's another way to motivate teenagers. An endo-goddess, Dr. Jennifer Dyer, that's, you can see why she's, by her photo, why she's endo-goddess. She's a pediatric diabetes specialist who discovered that if she emailed her patients, her teenage patients, they wouldn't reply, but if she texted them, they did. And she did a pilot study in which she demonstrated that by texting them, she engaged them and got them to check their blood sugar more often, and they ended up with better control of their diabetes. So that's another way, and the reason I mention this is that teenagers are often the hardest patient population to engage, and she was able to do it using technology. This is not the future. This is the near future. This is the very close to the present. That is an electrode which senses heart activity. It can be placed on the chest using an adhesive electrode, and the electrodes can be connected to a smartphone, and the smartphone not only detects the rhythm, but can use algorithms to analyze it. And we are very close to the day when a patient will come to the emergency department where I work with a smartphone reading that says, "I'm having a heart attack. Take me to the cath lab," and they'll be right. And our first impulse is to say, well, they must be wrong. So are we ready for it? Are health consumers in general ready to engage in their personal health? Are health professionals ready to accept patients as partners for better health? I've given you some reasons to think not, but and one of them is we're passive-aggressive. We're very good at throwing out roadblocks and objections, and privacy will be the big one. They'll always cite privacy. We're going to violate patient privacy, so we can't do this. And it becomes a deal breaker. And the question we need to ask ourselves is this a real concern or is it exaggerated? I would be remiss if I didn't close out my remarks. I'm very pleased to have given this keynote. Sweden and Canada have many connections. Matt Sundin has provided 2 of them. Matt Sundin, of course, one of the superstar hockey players, gold medalist back in 2006, and of course, a longtime captain of the Toronto Maple Leafs, one of the greatest centers we've ever had. And more recently, Matt Sundin has been giving back to the Hospital for Sick Children, forging links between the Karolinska Institute and the Hospital for Sick Children and the University of Toronto. And I couldn't be more proud to be a Canadian here in Sweden to say that. Thank you very much.
Thank you, Brian, and thank you for those illustrative examples of disruptive innovation within healthcare. They all seem very logical and very essential. And I actually had a question with regards to implementing these and how you foresee that. But before I see if I have time for questions, I wanted to head over to our commentators. And before you give some feedback, could you all just give us a one-liner of, your background or why you're here and so forth, so we get a bit of a grip of who you are, and then if you have any questions for Brian.
Yeah, absolutely. My name is Elizabeth Nelson. I had the honor of interviewing Dr. Brian Goldman, one of my favorite interviews for the blog Humans for Digital Health. I'm a PhD candidate in the Netherlands studying digital health and positive behavior changes. So talks like this are absolutely crucial in this movement, and I'm so happy to be here.
My name is Emma Spak. I'm from the Swedish Medical Association. We represent 46,000 doctors in Sweden, and I'm a training GP myself, and I'm responsible for e-health questions within the Swedish Medical Association.
And my name is Daniel Forslund. I'm the Commissioner for Innovation and E-Health here in Stockholm County Council. So I'm the politician responsible for making this digital transformation happen here in the Stockholm region.
I'm Anna Carlson. I'm president of the Swedish Rheumatism Association, who's an association for persons or patients with rheumatic diseases or musculoskeletal diseases.
And I'm Kristina Söderlund. I work at the Swedish Rheumatism Association as a political advisor, close together with Anne Carlson.
Thank you. What a distinguished panel. So do you have any comments or feedbacks or any insights with regards to Brian's speech?
Yeah, absolutely. We've actually been discussing quite a bit, so I think Emma should start. Actually.
Yeah, I do have a question, because I mean, it's a good talk, but we're barely scratching the surface. And in Sweden, we've had a lot of discussions about chronically ill patients and elderly patients, and it's been really a focal point over the last few years. And we all agree that we need this disruptive innovation and change within the healthcare system. But what I'm looking for is, how do we actually make that happen? How do we stimulate the disruptive innovations and the change? And that's what I was kind of lacking in this talk. So I would really like to hear your points on that.
Well, I've provided some hints, and I'm hoping that you'll run with some of these hints. I think the two of them from my talk are flipping the perspective. What patient engagement means or patient and family-centered care is flipping the perspective, and instead of designing a system as we have right now that seems to suit doctors and other healthcare providers, flip it around and ask patients, what are your issues with the way the system is running? And I would start not with care, I would start with navigating the system. So for example, I recently spoke to a group of mothers of children with complex illnesses. And these are fragile children born with rare, often genetic diseases. These are individuals, these are parents whose kids have 10 or 15 specialists. They're on 20 different medications. They might be managing 3 devices at home, BiPAP machines and J-tube feedings and nebulized Ventolin. And the parents have seen their kids die many times. They've seen them enter the healthcare system many times. And what drives them crazy is that each time they see a new healthcare provider, they have to explain the whole story again. And so they demanded from the clinic, why don't you generate a 1 or 2 page summary of every aspect of my child's care so that I don't have to do the talking, and especially when I'm under stress, and also so that the healthcare providers who are unfamiliar with my child can get up to speed quickly. That is a navigation aid that works. It came from asking patients what they need. We have assumed up until quite recently that patients have nothing to contribute to the conversation of how to make healthcare better. What if I said that patients have everything to do with making the system better? So that's the first innovation that I talked about, and so I invite you to think more about the role of patient and family-centered care. The second one is health coaches. Health coaches, that there's no question that in healthcare the English phrase is the squeaky wheel gets the grease. The more articulate the family member, the more they're able to achieve more for their loved one or for themselves in the healthcare system. A health coach can be that person for people who are disadvantaged. And so that's a way of raising the health literacy of patients in a hurry. That reminds me of the third thing that I would do. Health literacy from a very early age. Teaching health literacy at the age of 3, 4, 5, along with arithmetic and reading and writing.
It's a vital question, and I guess it's a lot to be able to answer just in a short summary. We're running out of time, but is there just a short commentary, an additional one? Thing with deciding? Yeah?
Yeah. I was just wondering, because the thing is, I'm not looking for what we're supposed to do exactly, but I think what I'm looking for is that I think that the leadership within the healthcare system and how we actually make the changes happen and stick within the system are the most crucial issue.
Yeah. And I have a question actually around that, because me as a decision maker, I have to give a mandate and the means to make this happen. And I was wondering, what would be the one thing that you would ask us to do as politicians or decision makers in healthcare to make this vision that we all share happen? What's the most important obstacle that we have to abolish to make this, you know, really be a true part of healthcare?
I would demand in the leaders that they buy into, that they believe in the patient perspective in their hearts. Because if they don't, then, and not simply as a marketing tool or paying lip service, because if they do it, good things will happen.
Patient perspective. Thank you so much, Brian. And please do continue the talks afterwards.